Welcome to Season 4 of Concussion Corner. My name is Dr. Jessica Schwartz, and I'm thrilled to have Dr. John Heick back with us today. Dr. Heick is Associate Professor at Northern Arizona University in Flagstaff, Arizona. Dr. Heick is a triple board-certified physical therapist in orthopedics, neurology, and sport, and he received his PhD in 2015 from Rocky Mountain University of Health Professions in orthopedic and sports science with his dissertation on concussion assessment. John, welcome back to the podcast.
Thanks, Jess. Happy to be here.
I'm happy to have you back. And we kind of left folks on the edge of their seat. This is how we nerds kind of do in this space, and until we get the conclusion, unless they wanted to read the paper themselves. But we'll hop back into talking about your recently published paper in IJSPT and on actually just lost your paper here on the VOMs. And standardization, the importance of standardization conversations with the VOMs. And kind of go from there. And one thing that I'll kind of kick off this podcast with is, the listeners here have heard this a few times, but we were talking, a little bit off recording about testing fatigue. And, on average, when folks see me, they see between 6 and 10 other clinicians besides myself. And that's why this is so important to talk about, to really understand where your patient is coming from. So understanding where your patient is at. And we just had Becky Bliss on the podcast this season, and we had that conversation with her as well. But for folks that are listening in, why is Jess so excited about this? And, why is John doing this research, this important research? One, I really hope to see the VOMs included on our international consensus statement later this year, if not this one in the future. And two, we really have to understand where our patients are coming from before they see us. So have they experienced physical therapy? Have they experienced OT, speech language pathology, athletic training, different types of physicians, neuropsychology, and so on? Have they experienced these other rehab providers, but what was their experience and what did they have done to them or asked of them? So it's so important to understand, hey, have they experienced someone doing the VOMs to them, but was it also done correctly? So I think that's, part of the excitement of when I'll ask you again, just to recap, for someone that just might be tuning in for the first time today, we'll have your first episode in the show notes if they want to catch up after they listen here. But, again, how did you kind of come to this realization that, hey, we need to standardize this? And what was your experience clinically and in the laboratory on how you kind of arrived here?
Yeah, I appreciate that. I think that when you look at doing vestibular rehabilitation or look at doing specifically concussion testing, you sort of develop these clinical patterns of noticing that as you're testing different things, you can, of course, get better at it. And so that's kind of led to this idea of specifically of looking at convergence. And of course, we know convergence winds up being this kind of black box, if you will, in terms of really understanding how convergence works. And that kind of led me to specifically this paper and looking at these different targets to kind of test. Does it really matter if I use my finger or if I use the tip of a pen? What you often see in the clinic, the tip of the pen might include a very shiny cover on the pen. It might include, some contrasting colors of bright blue and white, for example, and as well as silver. So now that really becomes kind of flashy, if you will, kind of like individual's ring as they're talking and you see their ring move. Oh, that's a pretty ring. We are just, in terms of humans, we are looking for those flashier looking things in terms of they catch our attention and our eyes specifically gravitate towards them. And so that kind of led to this paper of looking at different targets, and it doesn't really matter. And we did find that the size of the target mattered, as well as potentially we make this suggestion that the speed that you are moving the target towards the person matters as well. And we see that across the literature. Optometrists recommend, moving it 1 to 2 centimeters per second. And in terms of kind of calculating that, maybe that's a 1 Mississippi, 2 Mississippi, 3 Mississippi. In other words, a standardization of how quickly that target's moving. right? Because my guess would be maybe the New Yorker, Jess, this is a joke, it moves a little faster than someone from Arizona who's more laid back. I don't know that to be
you
true,
totally
right?
do. You totally do. It's not a joke. These are facts that we're spewing here on Concussion Corner. I have big trouble when I travel elsewhere. It's so funny. If I go to Italy, it's so laid back in Europe or in Italy. My best friend, my co-resident from NYU, is Italian. Shout out to Beatrice Beatrice Gerlani in Tuscany. She has a wonderful practice out there. And at the same time, it's so laid back, but they can get a cappuccino done before you finish the word cappuccino. So that's my homage to my Italian counterpart colleague out there. So
that's great.
But yeah, anyway, I digress. Yeah, that's so important to talk about. And that's something that and again, attention is our greatest resource, right? Everything is vying for our attention these days. So what are your recommendations in terms of using both font? Are we using the popsicle stick and a certain specific font, or what are we using to assess, for example, convergence and or smooth pursuit in the clinic?
Yeah, I think, if we were to bring that down to a nutshell, we go back to the original Ann Muka paper. The 12-point or the 14-point font is standardized. We need to print that out as an X, put it on the end of a popsicle stick. It works nicely to sort of slide along that ruler as you're doing that. In terms of a physical therapist doing that. Now, I will digress for just a second and say, an ophthalmologist doesn't do it that way. An ophthalmologist, when they're looking at how they look at near point convergence, they're not doing it as a screen. They're doing it as a complete test. So they'll use things like near cover testing. They'll look at a Maddox distance with a Maddox rod. They'll use also this Maddox Thorington test with a Thorington card. They will also use a Randot stereopsis in terms of using a booklet. And so they're not looking at a screen, they're looking at the full picture and evaluation just on this idea of near point convergence. And as you said, if you pick up the paper to read it in the discussion, I mentioned then that different disciplines have to agree on how we're going to do this screen as well. So it's kind of a shout out to the disciplines to say, hey, can we come together and agree on this screen, not the evaluation? We'll leave that for the ophthalmologist. That's their area, right? But let's agree on the precise way to do this screen across disciplines, just like we do in a clinical practice guideline of coming together as a profession and saying, this is what we found in the literature. This is our recommendation going forward. I think that should occur with convergence as well.
Right. And again, it all comes down to scope of practice, where, again, a lot of this has crossover. The injury of concussion has crossover in all sorts of different realms. You have someone, and I have a famous cartoon that travels around the world, and I can post that in the show notes. But, I got the idea and had my cartoonist do this of there's 10 doctors looking at the brain, and this one's like, oh, it's the neck. Oh, it's the vision, or this one, it's the vestibular system, and so on and so forth. This is cognitive. So again, you have to know what you're looking at, so you know what you're looking for. But again, respecting that ophthalmologist and optometrist, this is their life's work, right? So if we're looking at anything with ocular alignment, but to be able to identify these deficits and then making sure that we're referring appropriately, so we're not working out of scope. And also treating the patient as efficiently as possible. For example, Neera Kapoor is a friend of the podcast. She's been on a few times. Neuro-optometrist, one of the best in the world at what she does in this space. And she says, Jess, I see it all the time. And a few other neurooptometry friends and colleagues and neuro-ophthalmologists, say we see physios and occupational therapists that aren't super trained in either vestibular or brain injury or concussion, and they just have had like an amuse-bouche, basically, like a little sampling of
weekend course, right? Yeah,
exactly. We find that they're over converging the patients. So someone who may have a convergence insufficiency or not, or other accommodative issues with either autonomic dysfunction, which we know affects the accommodative system and things like that. They may be over converging when there are other concomitant things going on with the ocular motor system or the visual system. So really important things and salient points to take note of. If you're a listener tuning in and you're feeling a little uncomfortable, I'm really hoping that that's the case right here, because I hope this we're planting the seeds for you to dive a little deeper into this world. And this free open access paper in IJSPT, newly released in 2021, entitled Determining Near Point of Convergence, Exploring a Component of the Vestibular Ocular Motor Screen, Comparing Varied Target Sizes, is a great place for you to entree into, so you can start standardizing yourself in the clinic. So really important conversations that we're having here, John.
Absolutely, absolutely. And what we find is that then if these different disciplines are evaluating differently, then we might disagree on the patient in front of us of what's going on with that person, correct? So we want to correct that.
And that is traumatizing to a patient that has been maybe a persistent patient or someone in a very acute stage that has no idea what the heck is going on. And you said, well, I saw these 3 other doctors and I got all different information. That is very traumatizing to a patient who's trying to get their I am back. Concussion is a loss of I am. So for folks that are trying to, return back to their familial roles or professional roles or sport, whatever their concussion is threatening of their I am of that moment to get them back functionally, we really want to make sure that we're standardizing these things. And these are so important conversations on such a heterogeneous injury, with hundreds of different outcomes depending on their trajectory. So I'm really glad to see this work being done.
I appreciate that. And you referenced then that poor individual, athlete or otherwise, it's not athlete, maybe an older adult that had a concussion, they might be going through multiple disciplines to get that diagnosis and actually have some type of treatment. And I see that clinically as well. Mm-hmm. It's just unfortunate. You mentioned the idea of fatigue, and I wanted to bring up that aspect of fatigue and looking at that hasn't been explored for convergence. And we did see recently, I believe it was in December, don't quote me on that, but a paper looking at the King-Divic test and how fatigue mattered in terms of when it was delivered. Was it delivered after practice, or was it delivered, when the athlete or the person is fresh, if you will? In this study that I did in Convergence, we didn't isolate the terms of time. And so, we didn't always test everyone in the morning. For example, if we're looking at undergrads, they might have had 2 or 3 classes that day, came to our facility, and we tested them after that. We don't have that built in. That, of course, would be a limitation for this paper. But back to the clinical world, we have to think about that in terms of when I'm looking at the VOMs, so when I'm looking at convergence, when I'm doing some kind of concussion assessment, does fatigue matter in terms of how that athlete is presenting? For example, if my daughter's, like I mentioned in the first podcast, trying out for track, if she has a busy day of school, then does track practice, she's not out of track practice until 6 at night. Does that matter for her in terms of concussion assessment? How tired she is, what day of the week it is in terms of fatigue. And when you think about fatigue playing a factor, we do know there's specific literature that shows that whether we're testing saccades, whether we're testing smooth pursuit or convergence, that it does play a factor in terms of how the person performs in these oculomotor assessments. Mm-hmm. Have you seen that clinically, Jess?
Absolutely, John. And, and I think we've seen that even with other like neurocognitive testing, like if folks have to go to the bathroom, if they have to micturate, if they have to pee, we find that we find the same thing, or even with falls assessments and looking at falls, if someone has to pee, so there's all these other concomitant things going on in life. And I think, the concussion patient is a sensitive patient to schedule, right? I think, you're talking about fatigue, pre-post practice or after classes and things like that. When speaking of the concussion patient solely for clinical scheduling, I actually will tell my front desk, when I was in clinic and now I work for myself, but hey, we've got to have them either early. We're not putting them in that 4 to 6 p.m. hour with, Jimmy, John, and Jessica coming in, for rehab from either our football or soccer players who are off season, and we have Metallica going on in the clinic. We want to make sure, like neurosensory wise, like my outfit's right for my concussion patients. I wear very dull colors on those days.
Right.
Scheduling clinic times, and even my smell, I make sure not to have perfume when I have neuro patients. So all these neurological factors that we keep in mind with working with neuro patients is super important. And so, yes, documenting performance based off of objective measures is so very important. So if I'm seeing a patient at 4 o'clock, 6 o'clock, 8 p.m. or 6 a.m., I'm documenting the time and their performance and what they've already done in the day. Because again, in New York City, John, here, it's probably a little different than Flagstaff. They may have taken 3 trains, a subway, and, hitchhiked to try to get to me or vice versa. So I'm factoring all that in. Are they coming in agitated? Are they sweaty? If they have, dysautonomia, are they, did they just have a fight with a spouse? So all these things, factor into what we're doing. At the end of the day, with all due respect to our degrees, the vestibular exercises or PT or OT, whatever we're doing rehabilitatively, is not going to make a difference if, Sally, Joe, or John are in the midst of losing their home or job or on disability or in a no fault, battle. So really understanding where our patients are at is so important.
I agree. Absolutely agree. Yep. Have to do that and have to consider what's going on with that patient that's in front of you as you are evaluating them.
That's awesome. So, let's just finish here on the IJSPT article, and maybe we'll have time to hop into a few other things. But what were your conclusions with this VOMS article? What did you find that was best outcome for your metrics that you guys looked at for the study?
Yeah, it was kind of validating the Ann Muka paper, the original paper on the VOMS vestibulomotor screen to use a 14-point font size target. And whenever we change that to a different sized object, so 12 and 14 point were very similar. And so you could use a 12 or you could use a 14, but you would always stay with that same size for the patient in front of you. As soon as we change that size, now we get different scores. So we shouldn't be using our finger. We shouldn't be using the tip of the pen. We have to stay consistent and stay precise. In this standardized approach, which is recommended with the VOMS, is what we have to do. And to do that, if we use anything else, whether that's a different size target, or if we were to suddenly speed up the target movement, that could influence the score for that individual and may show someone that doesn't have a concussion, and or the opposite, that does have a concussion and not be able to recognize that individual. So that's the big thing and back down to the bite size idea is size matters with this paper and specifically in looking at convergence. And we have to be precise on these measurements.
And we're going size matters of a 14-point font. We're using black font on white paper, correct?
Yes, that's correct. And it's an X that's put at the end of a tongue depressor, so pretty much any athletic training facility would have, that include the physician evaluation may have a tongue depressor. We don't want to use other things. As soon as we do, we are impeding the standardization process of this test.
And I'm just thinking for future, John, are you thinking that should we be, it's kind of like a lot of the neurocognitive tests, like if there's a history of ADD or ADHD, are the people on their medication? Are they off their medication type thing if they're consistently on it? If someone is, has glasses on, I mean, we just want to make sure that we're using glasses if they, have acuity issues?
Yeah, clinically, I've always said, can they see the target without the glasses? And if that's the case, then I will test them that way. This is, again, a screen. So back to the idea of the ophthalmologist, they would say absolutely not, that the target should be adapted to the person's impairment in terms of the visual acuity. And that's why they use that thing they call the Thorington rod, the Maddox rod, and adjust the target to the patients in front of them. So they would adjust that target size. because this is a screen, I feel like we can confidently use that 14-point font, and that will allow them to be able to test. But I do use it clinically. Can they see without their glasses that 14-point target at arm's length away? And that's where our starting position is when we look at convergence. If they cannot, then I have them wear their glasses.
Awesome.
Yeah.
Awesome. Yeah, really important. And I really hope folks are paying attention. Again, you don't need the $100,000 machine here to do this. Back in the day, again, connecting to that, we are screening this, and that we're keeping in mind that our neurooptometry and our neuroophthalmology and colleagues and friends are here for picking up on anything, completely out of the ordinary. And then in terms of, vestibular wise, John, are you seeing anything in your patients in terms of what are you seeing that's being missed amongst other providers, either generalists or other providers that are being missed from a vestibular aspect, if they're not well versed in VOMs, or they've been, kind of mismanaged and being told to rest and not having, these comprehensive targeted physical exams for concussion done? What are you seeing in the vestibular realm?
I think one of the things that what tends to happen, and this is, more of an individual type thing, is you'll hear clinicians say, well, this is how I do it. And unfortunately with the VOMs, that's not what you want to do. The VOMs is very specific. You want to do it in this standardized way. So when you look at that as a vestibular rehabilitation specialist, right, you are going to do these vestibular measures differently than how the VOM suggests that you do them. So how I separate that out for me clinically is that when I'm looking at an individual that has a vestibular problem, I use my specific approach that I standardize for me in treating that vestibular patient. When I'm looking at someone with a concussion, I'm going to use the VOMs and do it a very precise way. And that recommended way is written out for us very nicely by Ann Muka et al. And so that is my approach, is I will separate that out and look at that. And knowing that I might be biased towards trying to do that vestibular approach, which I was trained in terms of clinical skills, but I have to do this standardized approach that's recommended within the VOMs. And I think that's what you were asking about, is how do I separate that? How do you do that?
100%. I'm completely the same way. So I'm trying to standardize as much as possible. And also, it also makes me much more efficient, because then, it's a 10,000 hour rule. If you keep doing things the same way, even the way I fold my towels in clinic was a specific way just to automate and save time. Really, it's just a decision fatigue thing for me. So I hope, and I know, so we're an audio podcast for now. We'll probably get into visuals in the next year, actually, for as a little sneak peek for folks that are listening in. But, I know, John, not to give away what you're wearing here, we're not that kind of podcast, but John is wearing our 100th anniversary APTA centennial. So physical therapy as a profession just turned 100 years this year. And we just built a new headquarters, a new HQ for the American Physical Therapy Association, which is a nonprofit organization in Alexandria, Virginia. And I bring that up because it's so important to connect to, this may seem so minute to folks listening in, but if you don't understand the history of where physical therapists come from, I'm one of our media spokespersons, people for APTA. And, my job is to kind of, I love to talk about PT. I love what I do. And I feel that John, with the triple board certification at PhD is kind of in the same boat here with me. He's
crazy, right?
Yeah. Right. And he's wearing, he's got the goods on today, his vest. But we really came up as rehabilitation aides 100 years ago, treating brain injured patients in the trenches, in a war, pre-pandemic, just before a pandemic, or just after a pandemic, I should say. And, at the end of the day, we were doing things because we thought they were good, and they either felt good, or we had an N of 1, which became an N of 10, which became an N of 100. And we were doing things. And I think as we've come up from a certificate to a bachelor's to a master's and doctorate and postdoctoral residency training, and educational doctorates with terminal degrees these days as doctors of physical therapy, we need to connect to this because our patients are only going to be better for it. And yes, we need to think in our own clinical toolbox, and not everything can be standardized or have a clinical prediction guideline whatsoever. But the things that we can standardize, we absolutely should. And for folks like concussion patients who are often mismanaged early because there is no standardized training in concussion across all spectrums, again, this is a place to build up, but most of this education in concussion management is done postdoctorally. So with that being said, connect to the standardization of the VOMs, connect to this paper, connect to what we may find in future papers, either by Dr. Heick or other practitioners internationally, but really connect to how can I standardize this in the clinic? How can I put some aides or interns to use? And, in the days of COVID, everyone's going to need their own popsicle stick now, right, John? So
that's right.
Print out those, 1,000 X's at 14-point font, and get to cutting and taping and putting them on the popsicle stick, because if we can standardize, one more thing in the day, and really, put research into practice next day for clinical knowledge translation, kudos to the people who are listening in and who are taking this stuff seriously. So thank you so much for your work and your service in this space, John.
I very much appreciate your time, Jess.
So for folks that want to reach out to you, John, what's the best way to find you on social media? Twitter, I think, is best way.
Yeah, Twitter's probably the best. jhike1 is my handle, and in terms of Twitter or email, of course, you can always look through Northern Arizona University's faculty directory to find my email address. I'm happy to entertain any points that you have questions about and/or that I can help you with, because I think, like you said, Jess, we're all in this together, and we're trying to benefit you all.
Yeah. And, for folks that are, as our students, our fresh PTs and coming up at Northern Arizona University, you really have a wonderful professor. And, if you can emulate just an eighth of what John is doing in our field, it'd be fantastic. And we welcome you to the PT family and to the rehab family from an interdisciplinary standpoint. So, John, thank you so much for coming on. And I hope to have you on in the future as well.
I look forward to it. Thank you all.